Good evening to all. On behalf of Women in Cardiology and the Related Sciences, WINCAR, it is my privilege to welcome you all to this landmark event on the occasion of the World Heart Day. That is of 2025, celebrated with a global theme, Don't Miss the Beat. This evening, we are together for the historic initiative for the first ever Indian scientific statement on the dyslipidemia in the women. We are happy that other associations are trying to write in the dyslipidemia in the pregnancy. Despite the high prevalence and the unique pattern of dyslipidemia among women, particularly across their hormonal and metabolic transitions, there has been a striking lack of women-specific consensus scientific statement from India. A recognition of this gap, WINCARS has been taken a lead to initiate this consensus effort, which will serve as a foundation for future randomized control trials and the national registries. I hope everyone will cooperate for that. It is dedicated to the women's cardiovascular health, as you know, that WINCARS, and now wanted to extend to conduct the randomized trials and the national registries. We are truly honored to have my co-moderator as a Dr. Ram Mohan, who is a CPMR specialist from the Nellore, along with our other esteemed chairperson, Dr. Daya Sagarao sir. He's a senior interventional cardiologist from Hyderabad, and I think sir is joining within a short. He's going back to he's already there. Good, excellent. And Dr. Sheba Thakur, the professor of Dayananda Medical College, Ludhiana, and we have the Dr. Sujata. She's an interventional cardiologist from the Vizag, and Dr. Sarita, an interventional cardiologist, well known to everyone. She's working for the Apollo Hospital, and another experts. She's a senior interventional cardiologist, director of the cath lab from the Apollo Hospital in Indore. And there are then other very senior people are joined with us, like Dr. Samraju sir, many other people who I'm not naming them. Please don't think that I'm not naming them, because Shiba is there to thank everyone for your presence, because it makes all the difference to make this consensus statement. That's why I'm thanking each and every person, even Geeta Subramaniam madam. So many seniors are there with us to help us. On the behalf of WINCARS, I extend my heartfelt gratitude to all the contributors, our senior leaders, expert members, and colleagues who dedicated and collaborate the spirit, who made us this scientific document possible. The flow of the today is going to be like this. Like the first, we will present the scientific statements, followed by the simultaneous polling and expert discussions, and ensuring the active participation and consensus building up. This will be completed by the panel deliberations under interactive questions and answers, and finalization of the recommendation. And I'm also delighted to announce that a specialist who dedicated to the dyslipidemia in the women, featuring the 11 articles, which is already I mailed to almost each and every person, along with this consensus statement. This publication will not only enrich the scientific literature, but also inspire a future research policy change and the clinical practice tailored to the women in India and beyond. And now we will start with an actual program. Can we request Dr. Ram Mohan to share his slides? It is going to be like this. First, I will tell a small introduction, and then Sarita will introduce the people who are writing that article in our special issue, and she will ask for the scientific statements. And then Dr. Sujata will ask the poll questions, and Dr. Shiba will ask the experts. And Dr. Daya Sagarao and all other experts, please raise your hands if you don't mind anything. Because you being a seniors, and I request to please raise the hand is not a good option, but to have a proper recording so that we can write a proper documentation. They are going to mute all of us unless we are the talking persons. Thank you for your cooperation. So this dyslipidemia in the woman, next slide, please. The first article is on the lifespan and the lipoprotein metabolism changes that occurs in a female. So just I will give a 3-4 sentences about an article, and then we'll go to the Sarita for the further proceedings. So the major difference from the Western to our Indian population is the social and the dietary. The social factors which contribute is the family priorities often delay lipid testing in women. Cultural taboos around the menstruation, menopause, and PCOS influence awareness and treatment seeking behaviors in India. This is true for the every component of the cardiovascular disease problem in the female, so also for dyslipidemia. High refined carbohydrate diets and the vegetarian patterns with a poor omega 3 intake worsens the dyslipidemia risk across the female lifespan stages compared to the global standard. Early atherosclerotic burden, which is very well documented in Asian population, especially in Indian females, premature CAD and PCOS. In addition to this male, these problems becomes a major metabolic syndromes in the females, and these are very much pronounced in Indian women compared with that of international cohorts, requiring urgent preventive strategies. Existing protocols rarely stratify the age and sex. India urgently needs a lifespan specific guidelines for screening and managing the dyslipidemia in the girls, reproductive age group, and postmenopausal women. Sarita, please. Next slide.
1 minute. Over to Sarita, ma'am.
Good evening, everybody. This article has been taken by our lead author is Dr. Asha Mahilmaran, and we have co-authors Dr. Purvi Parwani, Dr. Nagin Bhupati, Dr. Sridevi, Dr. Prachi Sharma, Dr. Rajeshwari Nayak. And I'm looking over it in an editorial note. Now, do we have our lead author with us, Dr. Asha Mahilmaran, to give comments about this article? Dr. Asha, are you there?
I think Dr. Sridevi is there.
Dr. Sridevi,
I'm
any
there,
authors in
Sarita.
this session?
I'm there, Sarita. Yeah.
Okay, Dr. Asha. So
Yeah,
we'll
yes.
take the comments from you, Dr. Asha, for this
Yeah.
article.
So we have showed the lifestyle variations, the lifespan differences in lipid profile over a span of life in women. So beginning from the differences between male and female in younger age and what happens with menopause, we have highlighted in this study. Also, the changes which happen with pregnancy and PCOD has been highlighted. So this is the focus of this study. And there is an increase in triglycerides. There is a drop in HDL. There is an increase in LDL. And lipoprotein A mainly has 2 peaks in women. Unlike in men, where lipoprotein A measurement is required only once in a lifetime, here there is both an increase initial normal level, and then after menopause there is a second increase. So 2 times we need to measure lipoprotein A in a female. So this has been highlighted in our article.
Excellent points, Dr. Asha. So this article 1 has been very well written by all the authors and the co-authors. What we have seen that it has started with a general screening and a fasting or a non-fasting lipid profile. And we've taken data from all the Indian studies, that is the ICMR, INDIAB, and the CAR studies, which have shown the earlier onset, which is leading to earlier screening for our Indian patients. Lipoprotein A, as Dr. Asha has said, that we have 2 peaks, because for all other people, it is once in a lifetime, but for a woman after menopause, the levels changes. So we are going with the point that it should be checked once more, because post-menopause is the time that the CVD risk also increases in women. And then it starts right from the adolescence and early reproductive time at which lipid screening should have started in a woman, especially for women who are at higher risk, who have obesity, who have PCOS, type 2 diabetes, or a family history of premature coronary artery disease. Again, we've stated that PCOS should be recognized as an important risk factor. Preconception and pregnancy planning, that is the time at which statin has to be stopped just before pregnancy. Of course, hypertriglyceridemia in pregnancy has been looked at in this, and especially for people who have greater than 500 or 1000 they've looked at the point that a low-fat diet, omega-3 fatty acid, strict control, and if TG is greater than 1,000, then the high risk of pancreatitis and things have to look at this. But we've only got Indian case series reports with high maternal morbidity and mortality. And again, we've looked at the data for homozygous familial hypercholesteremia, very limited availability of data in this, but there's also significant maternal and fetal risk in this. Postpartum lactation, they've looked at the point and they've looked at the fact that statins should be resumed after post breastfeeding to again achieve the targets. During pregnancy, again, is a big question. FDA has removed it, but it has to be a risk and benefit consideration and a lot of discussion with the patient and the family about all the things. And very high levels need to be treated. Perimenopause and menopause, again, they've looked at the point that LDL and TG levels would rise and intensification statin therapy and ASCVD risk rising. They've looked at the LDL targets. Again, we've looked at the targets of the extreme risk and the extremely high risk group as more aggressive targets. And then, of course, the role of primary prevention for people who have high therapies and high levels, extremely high levels. So this article is all about that. And throughout the entire stages of a woman's life, it deals with all of that.
One question,
We'll go now
for
to
Savita.
Paul.
One small suggestion, Sarita.
Hmm.
We are almost 300 WinCar members, and if we put together our data, we will have some data instead of quoting ICMR. I think we should come out with WinCar's data. So only when we have our own data, any guidelines or any kind of position statement becomes stronger. So I think we have to side by side work on collecting data, at least 100 women per member. We will have humongous amount of data. I think we should take it forward to that. In fact, Lipid Association of India started getting recognized when they started presenting abroad their data. Only when data was presented, they started getting respected. So I think WinCars will also hold a place in position statement only when we produce our own data. I think we should take it forward in the right way.
I think that's an excellent suggestion, Dr. Asha. And earlier also we had tried for this exact very same thing. With your suggestions, we will once again do this once again, and we will create the proforma and circulate it to each and every member with a timeline for the collection of the data, and then do an assessment of that and try to get our own data through it. I think this has always been Dr. Jyotsna Madam's dream that we should do this. We've tried in the past, but there's been issues, but we will do it again. And this time, hopefully,
see, in the LAI Care, where we can load it onto the mobile, the app kind of, that was very, very user-friendly. If we can come out with something like that, then it will become much more easier for the participants to contribute, and it will become easier, and we can keep it transparent as well.
We can.
To add your advice, Dr. Asha, we had already collected the information from the WinCars members of 123, which the data the Shiba is going to present at the end of this meeting.
Sure, ma'am.
We already started collecting, and we got the data now of our own WinCars people, of the 123 people.
Sure, ma'am.
If you permit, ma'am, Dr. Prabhakar Dorairaj has a comment to make, and he might leave after that because
Dr. Prabhakar, please.
So thank you,
go
sir,
ahead,
for
Dr.
being
Prabhakar.
there. And,
Yeah, thank you. First of all, what Asha was saying, the LAI Care study, that's a very simple study, but the point is there will be a lot of bias. You'll have to have a cap of 100 patients per doctor. And in primary prevention, the best thing is a lot of you are from Apollo. Take all the Apollo hospitals' master health checkup data. You'll get a complete set of data for women. You can compare with men and publish it. That will be the easiest set that is already available. If you want to expand it, use the other private labs also. You already have the data. You don't have to go prospectively. And retrospective data does not have any problem. That will be the easiest way to get your data easily. The second thing is regarding your LP(a). Though you say there are two peaks, the second peak that happens after menopause is only about 20-25%. It is actually the global recommendation to say that you recheck only in those persons who have a moderate elevation, meaning 30 milligram per deciliter is the LP(a) value that is acceptable. More than 50 is very high. So if you're somewhere in the gray area, those are the people there you ask them to check again. Not everybody. It's not required. So I don't think we should give a wrong recommendation there. 20% from 10 milligram is not going to make any difference. So don't recommend it for everybody.
So
The
should
third
we
thing-
say, Dr. Prabhakar, that only for people whose first report has come above a certain level?
Exactly. So if you're
So
moderate
what would you
elevation,
like that cutoff level to be, above 50 or above?
the accepted value is 30 milligrams per deciliter.
Yes, but we only start saying that it's very high and something needs to be done after it's
At
50.
50. After 50, there's no treatment. So it really doesn't matter. It's just a risk stratification. That's all.
Uh,
But
So if
we
you're-
do have Pilacarsen, which is now,
it's going to come 2 years from now.
they've
Still
made
not
it
available
available on
commercially anywhere in
compassionate
the world.
ground.
It's not commercially available anywhere in the world.
Yeah, but on compassionate grounds, they've offered it to us.
So I don't think we can talk about that till we have an Indian DGCA approval saying that it is going to be possible. We can say that these drugs are coming in the pipeline.
Okay.
We can say Pelacarsen, Olapisarsen is both, that is also presented recently. 2 drugs are coming up in the pipeline, very promising, 85 to 90% improvement in LP-little a. But we can talk about it. But the recommendation can be 30 to 50, you can check again. If it's more than 50 anyhow, it's high risk. It doesn't matter whether it is going to go from 55 to 60 or 65 to 70. I think it's fine. So the borderline patients are the one where you have to check your LP-little a again. The next thing is, see, triglycerides are the ones that are more specific for women. In men, triglycerides are not very prognostic, but in women, triglycerides are very specific. And Indian triglycerides, Indian women have a triglycerides that go up and HDL that comes down. So there is something called the triglyceride by HDL ratio, which might be more specific for women. So why don't you make a difference and project and say, we will look at TGL by HDL for women, which is more specific than possibly non-HDL, or once you get the data, we can always collect it.
I think great points, Dr. Prabhakar. I've noted down both your points. 30 to 50, recheck again LPA after menopause, and TG-HDL ratio. This is something we need to incorporate. Thank you so much.
Sir, there is in pregnancy, I mean, I came across a score chart where, or in otherwise also, the lipoprotein A levels. Do you have any comments for that being checked during pregnancy?
Not required, because that goes up and comes down. It
Mhm.
elevates and comes down to normalcy post-pregnancy. So you don't have to
And
worry about that.
Another area where I read about it was the use in the women who are menopausal and who are relatively low risk, when the decision for a transdermal estrogen or hormone replacement therapy has to be planned. So in women who are having lipoprotein A levels which were more than 50, it was cancelled. However, the women who were having lipoprotein A levels who were low risk, less than 30, if at all an HRT had to be used, it could be used. So it was there for a score chart. Any comments for that, sir?
I'm not sure about that, but you can make it as the risk modifier for doing this, for HRT. The
Yeah.
other thing that you can probably do is a pregnancy that you have to discuss a lot in detail about shared relationship. Dr. Sarita already mentioned about it. That is fair enough. But I think one more thing you should highlight is all the changes in the lipid metabolism that act perimenopausally. They start 1 year prior and proceed to 2 to 3 years postmenopausal. Now, this can be blunted to a very large extent by exercise starting in midlife, which is preventive. I think you must highlight that point tremendously, because that is important practically, and that is what should be highlighted to the obstetricians and gynecologists. And I'm sure you are highlighting all the pregnancy-related risk factors that are listed out in the
Yes, yes, sir.
ESC guidelines. I think that is
Sir.
very neglected and has to be highlighted.
Right, sir.
Can I add a quick comment? This is Neelima category. I appreciate all the input with Dr. Mahilmanan and also Dr. Sarita Rao, the doctors. How about emphasizing how much of exercise instead of just mentioning exercise, whether it's walking or running or jogging or whatever, the strength training, because a lot of Indian women, I noticed that they don't know what really exercise you mean to say. They walk inside the house and they think it's an exercise. So I would like to emphasize on the exercise, be more specific on that. Also, one question I have is a statin during pregnancy, or statins. I know you stop during pregnancy, but before and after, is there any dose limit for women of pregnancy age or women during their at the time of conceiving? Is there any limitations as to how much dose they need to be on? or there is no limitations on the dose when they are about to conceive? Because women don't know until they are pregnant until like 3 months into it or more than that. So is there any harm in the initial 3 months of conceiving, or no harm, or dose
I
doesn't
think
matter?
we'll be coming over to the questions on statins in the coming talk. This article was on lipoprotein A, Dr. Nilima, and there are a few poll questions after that. There is another article on statins and pregnancy. I think we'll be coming over to those questions also. Am I right, Sarita ma'am? Is
Yes,
it like
absolutely. Dr. Nilima, your points are very well valid.
we'll be coming
All we
definitely to the
discuss, so we know at what point it will come, and then we'll take up your question at that time. We'll move to the poll questions because there is a time limitation. Dr. Prabhakar, just one thing. Would you like to make a recommendation for the exercise?
I think there is nothing specific for women from the AHA standards. It's pretty much 150 minutes, but I think it will be interesting if you add the digital, the what you use your mobile phone and the step count. So anything more than 5,000 starts, even starting from 2,000 benefit, and it goes up to about 10,000. You can probably quote one of these studies, and it might add some value to the whole discussion.
Okay, so
I
we'll
have
make note.
quick comment. I have a quick comment, Sarita. There was a study which was published in JAC which said 140 minutes is enough for women compared to men, though they will start getting more benefits up to 300 where it peaks off, and strength training 3 times men, once in women. That was published in JAC last year. But there's no Indian data.
Okay, so we'll check this point out also, incorporate it. Also, we'll try to look for Indian data. Can we move quickly to the poll questions, Dr. Sujata?
Next slide. So all of you will receive around 20 seconds to answer these questions. Please be ready.
How do we answer this, Dr. Sujata, in the chat box, or this will the polling?
No. There will be can the torrent guys get the thing up? Do
The
cultural taboos delay lipid screening for Indian women? Yes or no? Torrent guys?
Yes, ma'am. Udharji?
Can you start the poll?
Yes, ma'am.
Go back.
Okay, the series is different, ma'am, as per the questions.
You just project your questions here. We'll see
Project whatever you have, please.
I have question of, do Indian women face delayed lipid testing during the monopause?
Yeah, project it.
Okay, ma'am.
Project whatever you have, please.
No,
So do Indian women face delayed lipid testing during menarche, menopause due to family by social neglect? So please submit 20 seconds. If the 20 seconds are up, please put up the answer and then we go on to the next question. Yes. So 82% have answered yes. Can we go on to the next question quickly? Next question, please.
Yes, ma'am. Yes.
Everybody can answer this question. Do PCOS related lipid disturbances appear more severe in Indian women than Western women? Yes, much more, slightly more, same, unsure. You can answer this question.
Requesting everybody to answer.
I think if 20 seconds are up, you can project the answer.
Including Sarita.
I have projected
everyone
answer.
can say.
Yeah, we are all answering, Jyotsna.
Yeah.
So yes, much more 50%, unsure 30%, and slightly more 13%, same 7%. Can we go on to question number 3?
Yes, ma'am.
Do Indian women develop CAD earlier due to menopause and PCOS related dyslipidemia? Yes, no, unsure. So we'll poll 4 questions, whatever, and we will go on to the next. Yes, so majority have answered yes. So we go on to the next question, number 4.
Yes, ma'am.
Should India introduce lifespan-based screening protocols for women? Yes, no, unsure. So I think after these 4 questions, we'll go on to the expert comments and then we go on to the next article.
I think already
Dr.
Shiva
Sujata,
has taken the expert's opinion,
Yeah,
so we
we
can go to
already
the
have.
second paper.
So we'll go on to the next paper. So yes, India should introduce lifespan-based screening protocols. So we go on to the next article.
article.
Dr. Ramohan, can you go ahead?
Yes, ma'am.
Next article, please. Genetics.
Article 2.
Yeah.
Article 2, genetics and clinical trials. The discussion domains are South Asian polymorphisms, predisposed Indian women to higher triglycerides, lower LDL, and early CAD compared to global population. Western guidelines overlook ethnic genetics. India requires population-specific risk scoring tools and female-focused genetic panels for accurate lipid management. Women are underrepresented in Indian lipid-lowering clinical trials. Regulatory insistence on adequate female recruitment is essential to ensure balanced evidence generation. Research neglect reflects gender inequalities. Empowering women to participate in research requires awareness drives, family counseling, and reduced stigma around the clinical trial participation.
So in this article 2 on genetics and clinical trials, our lead author is Dr. Lalita, and the co-authors are Dr. Yogeshwari, Dr. Venkatalakshmi Gautami, Dr. Srinivas Rao. The editorial role has been fulfilled by Dr. Nilima Katkuri. Dr. Nilima, I just heard you. So Dr. Nilima, could you please tell us about your article?
Yeah, I am online, but I'm not able to open up my article. I'm sorry. If we can move on to the next one, I will just get these things started.
No, you can tell me
give us
orally, Nilima.
yeah. Could you just give us a short overview of the important points that you've raised in this?
Yeah, I kind of did some clinical review on this, and I saw like very few randomized trials related to specifically Indian women or even women, as a matter of fact. And statin therapy, as usual, has shown to reduce the primary prevention, but secondary prevention is less clear in these women. So there are still data ongoing about the PCSK9 inhibitors and all of this to evaluate the safety and efficacy in women. So honestly, I would say there is not much of a data in the literature.
Have you made any scientific statements for that, Dr. Nilima?
Yeah, I just put it like there is not much data in regards to Indian women. So more studies need to be done looking into this specific relation. Did you guys find any data, or are you aware about any data?
Do we have Dr. Lalita also? If Lalita is there, she said she'll join briefly.
Yeah. Pavani, you informed her? Sarita, I sent what Lalita said, the scientific statements. you can read through that. Meanwhile, we can have the poll and you can see in that.
Let
We
me
can
just
have the poll
Dr.
and by the end of the
Lalitas.
poll, you can be ready for that.
Torrent, can we go on to question number 6? 5 we already answered.
Oh, did we? Okay, 5 we already answered.
This
No,
has been answered. Go
I
to
missed
do
it.
current global guidelines adequately reflect Indian ethnic genetics. Poll question, please. Do genetic diet interactions worsen early CAD in Indian women compared to Western women?
He's not yet started the poll. We have to see the poll question.
Poll question
Yeah.
is already on, Jyotsna.
Just now I got it. Yeah, thank you.
So this is what they feel. 57% felt that it does. The rest are equally divided. We can go on to the next question. Are Indian women adequately represented in lipid? So should India develop its own genetic risk scores for women? So everybody answer, please. Please don't look at this. There is a certain discrepancy between what we are projecting and all, but we will stick to what is being projected and where we can answer. Okay, Torrent, please. Yes, it is very obvious that we should develop our own guidelines. Next, question number 8. Should Indian women be mandatorily included in global lipid trials? So please answer, everybody.
Just 1 second. Jyotsna ma'am, you have sent it to me on mail or on WhatsApp?
A mail.
On mail.
Okay, so 84% feel that we should include Indian women, I think, to make the results more generalizable to the global population. So I think, Sarita, if you're ready with the consensus, we go on to the consensus and then move on to the expert comments.
I have not received Dr. Lalita's.
Okay, we will go to the next one.
Yes, because I have not received her.
Any
Okay.
expert comments on related to this topic regarding genetics? Anybody wants? Okay, if it's not, then should we move over to the next one?
Yeah.
Probably Dr. Dagasagara Rao sir want to add anything?
Yes. As of now, we do not have any data regarding the genetics being used for either classification or response to therapy.
Yeah. So we go on to the next.
This is about the autoimmune diseases and the dyslipidemia. As we already know that family neglects often the delays the autoimmune disease diagnosis. A woman frequently normalizes the symptoms, leading to a late detection and the poor lipid control. Many of the things which are non-specific symptoms for the autoimmune, they will consider as their exhaustion. So that's the reason autoimmune diseases takes a longer time in a female to diagnose, even though it is frequent. As the diet effect is the same as in a previous one. Because of the large carbohydrates and the vegetarian diet, not because of vegetarian, because of the large carbohydrate, they are likely to have the more dyslipidemias. So the premature CAD, strokes, and subclinical atherosclerosis are significantly higher in the Indian women with autoimmune disease when compared to the international cohorts. Almost this is highlighted wherever there is a comparative study is done, not only in the Indian population, even in the Western, where the Indian women are the studied, like in the US, when compared to that of the Indian women with autoimmune disease. This is documented. So we should have an international lipid guidelines may not adequately address the Indian autoimmune cohorts. So we should have our own guidelines for that. So over to Sarita.
Can you go to the next slide? Now, this was on autoimmune diseases, and the lead author of this is Dr. Chabi Satpathy. Now, Dr. Chabi has been co-authored by Dr. Srimanta Parida, Dr. Birja Prasad Berrio, Dr. Namita Mohanty, Dr. A. Selva Bharti, and the editorial role has been done by Dr. Chabi Satpathy. So, Dr. Chabi Satpathy, can you give your statements which you all finally decided from this article? Or any of the co-authors who are here can go ahead and give on this, because we have not received it. So Dr. Chabi is supposed to present this. Is Dr. Chabi there?
Dr. Kumar and Pavani, almost all these things are forwarded to both of you people also. Whatever they sent it, everything was forwarded to all of us.
Yes, ma'am.
Madam, should I go to next slide?
Can we take any, Shiba, can you take any expert comments on this meanwhile?
Yeah, surely. So, ma'am has already mentioned that how autoimmune diseases accelerate the occurrence of coronary artery disease. Any expert comments? Because this is one field which I think all of us face in our. So, any expert comments by the time we start with our poll? So, if no expert comments, can we have the poll by the time the Torrent people, please show the poll for the autoimmune.
Yes, ma'am, I have launched.
Yeah. So it's already, do Indian women with autoimmune disease face delayed diagnosis due to family neglect? So most of them have presented as yes. Can we go on to the next question? I'm not able to see the question. Shiba, if you're not able to see, please present. Okay, how strongly do India dietary patterns, vegetarian, high carb, low omega-3 affect lipid profiles? So I think all can answer. Next question, please. Answers of this.
Yes, ma'am.
So most feel that either moderate or strong effect. So very strong effect, 21%. So we'll go on to the next question. So do Indian women with SLE and rheumatoid arthritis have higher burden of a higher burden of premature CAD and stroke than global cohorts? So that's the question. So yes, much higher. 2/3 feel that it is much higher. So I think we go on to the next question. I think there are 4 questions. So are international guidelines adequate for Indian autoimmune women? Okay. So many feel that we need India-specific protocols. while others feel that they need just minor changes. So that completes the autoimmune section. And if we can have the consensus and the expert comments.
Dr. Sujata, only one question I have is autoimmune diseases, many of these patients will be on immunosuppressants and immunomodulators. So what impact do these drugs have on lipid profile? We should have some clarification included in this article.
That's
Yeah.
interesting. Yes, surely.
Yep, I'm reading out Dr. Chabbi's recommendation.
Yeah.
These patients are with an inflammatory joint disease, need regular pediatric screening for the dyslipidemia as suggested by the European leagues, which is proved to be in Indian circumstances also. Counseling for the lifestyle changes and aggressive treatment of the traditional risk factors is required. So it becomes a class 1A recommendation. Multifaceted approach for the both at micro and macrovascular level, assessment of the vascular health by the pulse wave velocity is appropriate for them. So primary prevention is essential in a high risk group like an autoimmune disorders, that is class 1C, because randomized studies are not available. Aggressive anti-inflammatory therapy with DMRDs, especially is HCQ and TNF alpha IL-6 inhibitors, is essential to modify associated dyslipidemia. So this is class 1A recommendation as per some evidence and obtained from the Jupiter trial and the meta-analysis in the 1.5 patients of the autoimmune disorders where Indian population is also included. Low dose colchicine comes as an class 2A C as there are no randomized trials. So the dose recommended is the 0.5 milligrams OD. Moderate to high intensity statin should be considered as a first line of the people who has a dyslipidemia in this, and for a primary prevention as well as other inflammatory biomarkers, whether raised or not, depending upon irrespective of that, depending upon the lipid profile, we should start the first line treatment in them. That is class 1B recommendation. That is our recommendations about this. I think we can go to the next. Over to
Yes, ma'am.
Mohan. Yeah.
Article 4 is dyslipidemia in pregnancy. The discussion domains are social, dietary outcomes, and guidelines. Cultural and family beliefs delay lipid testing during pregnancy. And many
I forwarded this fourth article written by the Chabbi recommendations. Sorry.
Just got it, ma'am.
many women only seek care after complications like gestational diabetes. Traditional high-fat diet, carbohydrate-rich pregnancy diets worsen lipid profiles, increasing maternal fetal cardiovascular risk in India. Combined gestational diabetes and dyslipidemia are disproportionately higher in Indian pregnancies, heightening risk of preeclampsia and premature atherosclerosis. India allows pregnancy-specific lipid management protocols, customized recommendations should guide screening, monitoring, and safe treatment thresholds.
So thank you. Now, can you go to the next slide? Yes. So the lead authors, Dr. Hemant Kumar Satpathy. We have Dr. Namita Mahapatra, Dr. Bharti Das, Dr. Sashmi Prabha Sethi as co-authors, and editorial load is by Dr. Selvarani. We've received the consensus statement for this. Now, dyslipidemia in pregnancy, basically the increase in lipoprotein is important for fetal growth and development. So it starts from the 12th week and it reaches a peak at term, which is mediated by the estrogen, progesterone, placental lactogen, and the insulin restin. Now, TG during this period rises 2 to 4 times from pre-pregnancy values, total cholesterol 30 to 50%, and the size of the LDL particle decreases. LPA level again doubles from 10 to 35 weeks of pregnancy in 20 to 30% of the patients. And HDL and ApoA1 also peaks to mitigate their effect. So basically, and these return to normal 3 to 6 months postpartum. So the recommendations that they have made is that lipid testing should be included in routine prenatal checkup to detect dyslipidemia in 25% of pregnancy and familial hypercholesteremia in 0.4% in first trimester. Please don't keep the poll now. And if not screened earlier in pediatric age for high-risk cases, but latest at 20 years of age, they've made a class 1A recommendation for this. Second, they've made is measurement of lipoprotein A for all pregnant women. That's a class 2BC recommendation which they've made. Adopting healthy lifestyle with appropriate diet, physical activity, smoking and alcohol substituents. They've given it as a class 1A. Also, in normal pregnancy, lipid-lowering therapy should be discontinued 3 months prior to planning or immediately following pregnancy detection. That answers your question, Dr. Nilima, as a class 1A, they have said. Also, they have said that lipid-lowering therapy needs to be substituted by bile acid sequestrants if required, unless at very high risk. And for BAS and omega-3 fatty acids deemed to be the safer drugs for treating dyslipidemia and pregnancy. Bile acid sequestrants also not absorbed from the GI tract, so class 1A recommendation for that. Other drugs like estimab, bempedoic acid, fibrate, and niacin are considered after first trimester only when the benefit outweighs the risk in the individual. Class 2AB recommendation they have given. Injection inclisiran is offering some hope in severe hypercholesteremia just before and immediately after pregnancy. They've given it as a class 2AB from the European Heart Journal recommendation. They've also said lipid apheresis is a preferable option in pregnancy biweekly when feasible in severe refractory hypertriglyceridemia to prevent only pancreatitis or a hyperviscosity syndrome in homozygous familial hypercholesteremia as a class 1A. This is from the American Society of Apheresis. And severe hypertriglyceridemia refractory to treatment need early termination in 3rd trimester. So knowledge on lipid-lowering therapy in pregnancy is still poor. Lack of adequate data in pregnancy along with associated ethical considerations makes further prospect in this field very complicated. Management team should thus include the dietitian, the cardiologist, the endocrinologist, the obstetrician, and the dyslipidemia expert. We can now go to the poll questions.
So already this question has been answered. Do cultural family norms delay lipid testing during pregnancy in India? So most feel yes. Next poll question. Do traditional Indian pregnancy diets worsen dyslipidemia? So most people feel that they strongly agree that Indian diets, traditional Indian diets, worsen dyslipidemia. Next. Is combined gestational diabetes and dyslipidemia more common in Indian women than Western women? So yes, much more is the thing, is the answer. Can we go to question number 16? So should India develop pregnancy-specific lipid guidelines? So can you poll? Yes. So everybody agrees that we should give it our own guidelines. So can we go on to the expert comments?
Any expert comments regarding pregnancy and dyslipidemia? Dr. Nilima, I hope the queries, I think you were talking on statins. We'll have upcoming discussion on that also in pregnancy.
Yeah, thank you so much.
Just one question. In the poll, I saw that the traditional diet one is a thing which I mentioned, dyslipidemia. I'm not aware. Is there any study which has been done with this diet and your lipid profile? Because, it will become a very social issue. So do we have any study which shows that these diet are causing dyslipidemia in pregnant women? I'm not aware of, frankly speaking.
Any comments from the authors? Even I agree. I don't think we have any,
Yeah, because, it's out of our domain area, like diet and it's become more like a, emotional and a social issue.
yeah. We can check that, except for the fact that we can say that the diets which are being given are probably very, but we cannot comment that.
We cannot, we cannot, because these are related to your religious and your social things. So we cannot comment on that. If we have a data, then I agree with that.
Yeah, but it's a nice food for thought to generate data. Yeah, I mean
Because
yeah. So look at, but I really do not know, because in the last trimester of pregnancy, as we know and anticipate that anyways, we expect that 30 to 50% rise, the physiological rise, which is going to occur in cholesterol levels. And there is no cutoff which has been defined as yet, which can differentiate even between pathological and physiological hypercholesterolemia. But it's a nice food for thought. Any comments from the house?
No.
Yeah, I have a comment. Like while going through the literature, not in the pregnant woman, but as such in the women as whole, high carbohydrate diet is linked to the high triglycerides. So maybe Indian
Dr.
women with
Prerna,
high
that's my point. See, high carbohydrate diet, I agree that is there, but pregnancy specific, if you see the diet which you given him high in fat and ghee and all that. So should we comment on that religious thing or not social issue? That is my basic question. Otherwise, overall Indian diet itself has a high carbohydrate diet. That is not a question about we are
high
talking about.
carbohydrate.
Rupali, there has been a mention of African women having salt cakes during pregnancy that increases their eclampsia. So we also need to think, the kind of Indian diet that is.
So before giving a recommendation, at least we should comment that this is the data which we have, and then we should give a comment. What I feel.
I agree with Rupali. I think before any hard evidence,
We are not
we
giving a
can't comment on any
recommendation
religious
based on poll
things.
questions.
Yeah.
We are
Yeah.
not giving a recommendation based on poll questions, okay? We are, the recommendations are based on data only. These poll questions are just, we are raising the discussion, okay? So, can we
Rupali
go?
and Dr. Hetan, our discussion is for all the topics are given to the so many people for the same, to see the literature and to tell about it. So now you raised the topic, so they can ask, because these carbohydrates, which I was mentioning in the first two chapters or also, is already well-known factor. Carbohydrates are known to be associated with the dyslipidemias. So in pregnancy, you have the doubt. So for that sake, we are having this discussion, and so many people of the nearly 70 people are there to see that. I thought they will come along with the reports of it. Now, at least with the questions, they can go back and see that.
Dr.
The
Shibama?
recommendations
Agreed,
are
ma'am.
not based on the poll questions, okay?
All recommendations are based on hard data. So all the recommendations have actually been done by the authors and reviewed by one of the editorial board members, but each of them comes with a reference and with the data which has been with there. Unfortunately, many of our authors are not here today. Otherwise, they would have answered it.
Dr. Shiba ma'am, you have some comments?
No, ideally, to my understanding, we need not check lipid profile during pregnancy. You should have if possible, you should have a pre-pregnancy profile, especially in high-risk patients and patients with familial hypercholesterolemia, or those who have had established ASCVD. Otherwise, you do a checking only after the 3 to 6 months post-pregnancy. So need not check it during pregnancy and worry too much about it, unless there is late pregnancies and anticipation of complications of pregnancy like eclampsia, preeclampsia, pancreatitis issue comes up. All this because there's a strong link between pancreatitis and toxemias of pregnancy and elevated triglycerides in the 4-digit numbers. Otherwise, you need not check lipid profile at all.
Perfectly said, Shiba ma'am. So the recommendation which was made by these authors was that a pre-pregnancy test for all patients, so that they have a baseline lipid profile and we know which are the ones who are going to head for trouble. So pre-pregnancy was given as a class 1.
Yeah,
you're
that was even
getting-
discussed before also. Pre-pregnancy it is indicated, but during a pregnancy which is not known, there is a controversy because in the first trimester
Yes.
is knows to have the
Yes.
some lipid abnormalities. So can we call them? That's the reason why they are getting a separate consensus statement during the pregnancy. So should we go to the 5th article if there are no other comments? This is on the lipoprotein A, remnant C, and the non-HDL. LPA polymorphisms are the frequent in South Asians, and they drive higher premature CAD incidence among the Indian women. Elevated LPA and remnant cholesterol strongly predict earlier CAD onset in an Indian woman compared to the Western cohorts. And LPA testing remains an unaffordable and unavailable in many. When I found that and how many centers are doing, actually in Hyderabad itself, it is being done only in 40% of the pathology labs. And socioeconomic barriers hinder the widespread adoption. Targeted LPA testing for the high-risk group may improve the yield. Universal testing may not be the viable for in India. Over to Sarita.
So can you go to the next slide, please? Okay. This article, the lead author is Dr. Harish, and the editorial has been done by Dr. Sujata Vipadla. She has submitted her statement. So lipoprotein A values more than 20 are considered elevated in Indian women as compared to the 30 cutoff commonly used in Western populations due to the higher prevalence and risk association in Indians, especially with a family history of premature CAD. LPA measurements should be done in women with premature coronary heart disease, normal lipid profile, but definite evidence of CVD, recurrent CVD, despite treatment postmenopausal status, family history of premature CHD or elevated LPA. Elevated remnant cholesterol greater than 30 is an important risk factor in women with diabetes and hypertriglyceridemia, and its role diminishes if LDL is well controlled. Elevated non-HDL-C is considered a better predictor of CVD risk in both Indian men and women due to the high prevalence of elevated triglyceride and small dense LDL. Over to Dr. Sujata.
So basically, this lipoprotein cutoff of 20 was derived from one Indian study, and especially more so a Southeast Asian study. And what Jyotsna has said, that it is not widely available. So should be done. There was an article which raised the issue that we should do it only in women with premature heart disease, because we know that family history is a very important risk factor in women, and premature coronary artery disease family history, or a normal lipid profile but definite evidence of CVD, as Sarita has already read that. And this LPA has also been highlighted by Asha, that we should do it twice, and Dr. Prabhakar has already said that in the gray zone only we do it, we repeat it after menopause. So we could include that in our statement too. And that elevated remnant cholesterol, which more than 30 is an important risk factor. In one North Indian study, basically this data is from single studies and not multi-center studies. So we can only say that the evidence is class 2B. And that North Indian study has said that its role diminishes if LDL-C is well controlled. And elevated non-HDL cholesterol, we know, is a better predictor of ASCVD risk in both Indian men and women because of elevated triglycerides. And again, that is also not based on large studies, but single center studies. Can we go on to the poll and the expert comments?
Yes, I think we can.
So are LPA polymorphisms more common in Indian women? Yes, unsure is 38%. So next. Do Indian women with high LPA present earlier with CAD than Western women? Can we go on to the next question? So yes, much earlier, everybody believes that high LPA is responsible for the premature coronary artery disease in Indian women. Next. So is less LPA testing unaffordable for most Indian women? So this question has already been raised by Jyotsna that only 40% of the labs in Hyderabad are doing. It's unaffordable according to many, but some 30% felt that it is not because it's only a one-time testing. Next. So should routine LPA testing be part of lipid screening in India? So this question has been raised. Should we do it for all? Should we do it for high risk? Only for research? So 50% felt it is for high risk only, whereas approximately 40% said for all. So I think if you have some expert comments on LPA.
Yes, Dr. Harish, you want to pick a comment?
Madam, I would just like to discuss with you that LP usually we take more than 30 in routinely as of now we are taking, but only there are few some North Indian study with a few small group they have taken 25 more than 25, but we are not sure about the exact cutoff point where should we start. And what I've learned from this is that from the data I've seen is that the LPA elevation is much more common in Indian subset when compared to the Western data, what we are seeing, which the other guidelines have been showing. So that is my perception. And as far as possible, this because keeping it into as a screening, once we don't have an exact means a method of treatment, means how to manage it, the elevated LPA, we should not emphasize it on a routine screening. We should better keep it in a high risk subset. That's what my opinion is, madam.
Yeah. Thank you, Harish.
Right. So do we move on to the next thing if there are no more expert comments?
Just one comment. I agree with Dr. Harish that, routine screening rather first is that, only in high risk. And the second we can mention that routine testing in these cases is not recommended because since there is no therapy available, because it will create a more scare in the patient when there is no therapy available. So we can add one line in these cases on not a routine because since there is no specific therapy which is available to decrease the lipoproteinate till now, and only in high risk subset, we can have a more strict control with the available cholesterol lowering drugs. That was my suggestion.
Actually, there's a point in this. When we say that, okay, like I said, Pilocarcet is available on compassionate ground, but not clearly available to the patient as such. But if you look at it, inclisiran also does a reduction of 25 to 35% of lipoprotein A. So while we don't have targeted therapy only for LPA, but we do have other therapies which do bring it down because 25 to 35% reduction of LPA is also significant. What do we say about that?
It's what means Madam, what I've seen is that often we have found that even though the lipid profile means based upon the routine lipid profile, what we see comes normal, the LPA is around 30, quite a large number of people. So that could cause a little bit anxiety, as the other speaker was telling that, because we don't have a specific therapy to target it, the elevation of an isolated LPA. So yes, we do have that PCSK9 inhibitors do reduce it, but as far as now, still further studies come and further the modalities develop for targeting it, we should keep it in high risk, I think.
This is Dr.
Harish,
Dayasagar.
the point is well taken, but only point I wanted to say is what the cases we see in the OP are the already high risk cases. Very few cases we see which are the low risk, and we don't recommend as a routine to the LPA. So, but LPA not recommending just because treatment is not available should be the last option. It should be the reasons that classifying them as high risk, low risk, or intermediate risk is a much better. than saying that availability of the drug therapy. The drugs will be the start doing once you know the incidence. Suppose you know that an LPA then abnormality is so high in the Asian population is about 40 or 50%, then you do it. So till the time you don't recommend as a for a general population. That's what my statement also I added, that don't do as a routine testing. But in cardiology OP, what we see is an already high risk patients. Dr. Dayasagar sir wanted to say something.
I think there's a misunderstanding that lipoprotein little a is not a risk factor. It's only a risk modifier. So that is used more for classifying or reclassifying the disease. Second, there's a lot of controversy. What is the exact method of measuring the LP little a? Third, there is controversy about how to express the concentration of the LP little a, whether it should be measured as milligrams per deciliter or nanomoles per liter.
Millimoles.
Third, what we are considering is a marker of high risk. So if LP little a is higher than an arbitrary cutoff point, it puts the patient, reclassifies the patient as a higher risk as compared to otherwise it could have. Pelacarsen as a therapy, when it's available, it does increase the LP little a, but no change in the events. Made between biochemical effect and clinical benefits. A lot of other that where biochemical does reduce.
Is it disturbance in sir's voice or it is only for me?
No, we cannot hear him, ma'am. We cannot hear him.
We cannot hear, sir.
Sorry.
You are not audible, sir, actually. There is a lot of disturbance.
Am I audible now?
Yes,
Yes,
sir.
sir.
Okay, I think I'll go back to the first sentence because lipoprotein little a is not a risk factor per se. It is only a risk enhancer. So basically, if the LP little a is high, you reclassify the patient from a mild risk to moderate risk. Or if it is a moderate, it goes to higher risk. That really takes the endpoint or the target level of LDL to be achieved. Second, there's a lot of controversy about how to measure LP little a, that the methodology used to test the concentration. Third, even there is controversy about how you put concentration of the material that is LP little a will milligrams per or nanomoles per liter. There's a lot of controversy. And finally, what is going to happen as and cyst, we are all the high risk category. And then 50.
Your voice is breaking again, sir.
Again, last two
Last line.
sentences
Yeah,
we could
last two sentences.
Suppose if the LP little a is higher than 50 milligrams per deciliter, you certainly fall as a South Asian into a very high risk category. So your LDL-C target levels will come to less than 50 milligrams per deciliter. The drug that was used, pelacarsen, as I already told you. But then it is important to realize that there are some ethnic communities, especially the South Arabs, where they have very high levels of LP little a, and yet they do not suffer a high risk category. So it is both the level of the LP little a and the ethnicity of the patient that really matter in risk stratification. Now, to come back to the pregnant woman and then LP little a, there is no data to say whether it does good or does it harm the patient. We are not sure. We do not have data. That's my review of the literature, what I have done during my presentation.
Right, sir. Yes, sir.
Thank you.
Thank you. Thank you for your comments, sir.
Sure.
So do we now move over to the next question? Dr. Raman? Dr. Ramamohan? You need to unmute yourself.
Yes, ma'am. The Article 6 is imaging and biomarkers. The discussion domains are outcomes, healthcare access, cost effectiveness, and guidelines. Subclinical atherosclerosis manifests earlier in Indian women than Western counterparts. This detection leads to higher CAD morbidity. Rural women lack access to advanced scans like carotid IMT, CAR, or coronary calcium scoring, and widening urban-rural disparity. Biomarkers ApoB and HSCRP are cheaper and scalable compared to imaging, feasible in Indian resource-limited context. India should establish women-specific imaging protocols, balancing affordability, accessibility, and predictive value.
So this article number 6 on imaging and biomarkers, the lead authors Dr. Anuradha. We have co-authors Dr. Anjani, Dr. Nand Kishore, Dr. Panigrahi, and we have Dr. Shiba as on the editorial board. She's submitted a consensus that is, they say that the Indian women with borderline or an intermediate risk and age less than 50 can be considered for calcium scoring in the presence of multiple risk factors, family history of CVD or diabetes. After menopause, the coronary artery calcium scores increase steeply, and for the same coronary artery calcium score, Indian women have higher CV event rates. Third, they've said Indian women should use lower coronary artery calcium thresholds to trigger more intensive management. Coronary artery calcium of 0 is considered low risk, but vigilance, if high risk profile 1 to 100 is moderate risk, 101 to 400 is high, and greater than 400 is considered very high risk. Breast arterial calcification is a marker for cardiovascular risk in Indian women, especially those above 40 and with metabolic risk factors. CIMT greater than 0.57 millimeter or above the 75th percentile in women above 40 years, and earlier in those with risk enhancers or metabolic abnormalities like PCOS, to guide primary prevention and optimize the risk stratification. HSCRP, ApoB, lipoprotein A, non-HDL cholesterol, and oxidized LDL should be used as routine biomarkers for early CAD detection and risk stratification in women, especially those with metabolic syndrome or diabetic profiles. Dr. Shiba, you're in the editorial load. So would you like to add anything?
I think these comments suffice, and we've already mentioned that imaging may not actually be possible, though very much warranted. So we have some biomarkers which can be utilized for our Indian women when we are targeting dyslipidemia. Routine screening by using all the imaging methodologies may not be practically possible in for most of the women round the corner in our nation. I think I agree with whatever recommendations. We can go for the poll and any expert comments, if any.
Yeah, actually, Anuradha is there. She wrote the article. And Anuradha, you want to add anything?
Yeah, this is Dr. Dayasagar. Can I say something here?
Surely,
Yes.
sir. Yes, sir.
Coronary artery calcium score is really worthwhile in evaluating. It should be seen as a marker of atherosclerosis. That means atheroma has already started. That makes the patient more vulnerable for further atheroma. But the important caveat in that statement is people who are already on statins, the calcium score is much, much higher. This is basically the effect of the statins in stabilizing the already existing plaque by way of calcification of the atheroma. So there is a caveat there that if the patient has been taking, for whatever reason, been taking statins, your calcium score is unreliable in predicting the presence or absence of a disease.
Yeah, thank you, sir. Thank you for that addition. Actually, this calcium score thresholds like 0, low risk, 1 to 100, which is not even considered, is considered low risk in Western populations considering this in Indian women as moderate risk is based on just a single article, and we cannot give it a we can just give it a class 2B recommendation, because it's based on an article published in IJCWD, and editorial was written by I forgot the name. She has suggested that 1 to 100, which is considered low risk in normal Western populations, be considered as moderate risk, and 100 to 400 as high risk, and more than 400 as very high risk in Indian women. And breast arterial calcification and using calcification which is obtained on non-contrast CT scans, detection by artificial imaging, all these are going to be studied more in the future. And carotid intima media thickness is also based on one article published from North India. So I think we can, any more expert comments?
I just want to say that Lipid Association of India has used the imaging as one of the risk factors. The reason is for predicting the possible presence of a atherosclerosis, we do not have any predicting scores like what they have for ACCHA, like pooled equation, or in the European Society as score 1 and score 2. In the absence of, because that takes a very long time of comparing the association of risk factors with the onset of the disease, and the strength of association really dictates whether that factor should be taken. Second important point here is that coronary artery calcium score requires a machine where CT scan has to be done along with some software, and it may not be available all the way in all the places in the country. So what Lipid Association of India has done, as advised as a matter of fact, is to do femoral artery duplex scanning of the both lower limbs, femoral arteries only. If you find atheroma in those vessels, that means already patient has got atherosclerosis ongoing, and there is a need to be more aggressive in terms of approach to the problem by way of diet control, exercise, and pharmacological methods. So this is what the Lipid Association of India has advised for the men, or for that matter, Indian people in general and men in particular.
Why femoral artery only, sir?
Femoral artery, because that's the one that is commonly done, is available in most of these ultrasound centers, because carotid intima thickness requires a special probe and special software also. And most of the what we call ultrasonographers are not familiar with the carotid intima. They are more familiar with femoral arteries, because we are investigating more often for peripheral vascular disease. It's only familiarity and the accessibility of the machines and interpretation of the data. Because of these things, I'm not saying that femoral artery imaging is the ideal, but when you don't have coronary artery calcification score machines available, the next best is probably it is ultrasonographic evaluation of the femoral arteries of the lower limbs.
Yes, sir. Your point is well taken, sir. But I will ask Dr. Tripti, who done this one study. Always she quotes about this carotid intima thickness. The study was done from their center. So, Dr. Tripti, you want to add anything? She put that paper also.
Yeah, Dr. Josna. Actually, I have done myself, and sometimes I have seen Dr. Ramya had a discussion once, because she did her thesis for DM for carotid intima media thickness, but she is not specifically looking into the woman subset. But in my practice, when I have not collected data. I'm sorry, I should have collected data. But I have young women, those who come from IT sector, having family history very strong. I have done the carotid intima media thickness, mostly in Indian women. The carotid intima media thickness ratio should be less than 0.4, 0.45 or 0.5. But in our women, mostly I have seen it is 0.6 above and maybe sometimes 0.7 also. I don't know how to interpret and how to go about it, but we should have our own data for our women into the different age groups, like categorizing them into 10, 20, 20, 30 like that, 30, 40 like that, or premenopausal, postmenopausal, all those things. And then only if we do a very selective and categorical study properly done, and with a radiological, institute, they also give us some help with their proper algorithms and proper, like you said, there should be a proper digital mapping for these things. And then only we can make a real discussion and real propagation of our own data. But I don't know how to interpret it. But I was thinking, when I see this kind of intima media thickness going up, and sometimes I see some bulky plaques also, so which are coming up as a soft plaque. So not options to bring down the LDL cholesterol to below 50 for primary and below 30 for secondary. So most of the time my patients, they understand that this imaging, and they try to really reverse our times. But I'm very sorry, I have not taken any data. I should involve with our group, and I should take up in a forward position. Thank you for.
Madam, we have forgotten one important biomarker. It's called pulse wave velocity, which is easy to measure. Carotid femoral pulse wave velocity.
Yeah,
When I was doing my
but
when I
the
was doing
problem, Ramon, that is not available at every place, because we, as a research protocol, we have it. So that's why we have the multiple papers on that. That's why I'm not talking about it, because many of the research labs has it, but not as a routinely available ones.
it is one of the cheapest machine, madam. It is just
I know,
4
I
lakh.
know.
No, pulse wave velocity tells you that the arterial wall is abnormal.
Yeah.
But it doesn't tell you the cause of it. It can be arteritis, it can be atheroma, it can be part of aging without atheroma. So, although it does tell you that the arterial vessel wall is abnormal, but it doesn't tell you the cause of it. Whereas imaging the atheroma is totally different.
Yes.
It is much more specific, more easier to get it, especially by the ultrasonographers, which we have in plenty, and the transducers are available to do the peripheral vascular disease. It's much more easier.
Yes, sir. Your point is very well taken, sir.
Yeah.
Thanks. Any more expert comments? Else we move on to the poll for this round.
Can I add one comment, Shiva?
Sure, sure.
Yeah. So then regarding
Sir,
the
can
CMT,
ABI can be
so
used, sir, because
Harish,
Sorry,
after the Rupali, you can comment.
yeah, sure.
okay. So regarding the CMT, I agree with the Sir Rao sir also that it's you need a special software. Like from our institute, we did a patients with CKD in these patients, and you as cutoffs and all that. So we have calculated these normal patients without and calculated the CIMTs. The one more marker which we studied was FMD, the flow mediated dilatation in these cases. That also comes out to be one of the markers for having an increased events in these cases. So if we can have an opinion of the other house also, that can we add
That
this
paper
marker
is
also in our?
published, Rupali? The data is published
Yes, ma'am. I will share it on the group, ma'am. CIMT and FMD, ma'am.
from your institute.
Yes, from my institute, ma'am.
Good.
Any differences
We'll
with the
include
gender-based
it,
differences,
Rupali.
Rupali?
Sorry, ma'am.
Any gender-based differences were there in these patients, or
No, it was not analyzed according to gender base, actually. It was just patients with coming with. It was not gender based.
Yeah,
I will share it on the group.
can you share the studies so we will look at what percentage were women and we'll try
Sure,
to
ma'am. Sure, ma'am. I will share in the group. Ma'am.
So, Dr. Harish, if you have any comments, otherwise we go to the poll and then the next one.
Madam, one option could also be this ankle brachial index also could be used, no, madam, just because it's just a blood pressure measurement. It could be quite commonly used. That could also be one option.
Yes. Yes, surely. Yes, your point is well taken. It can be easily performed also with a routine tool and also in the OPD basis.
The same as Dr. Dasagar said,
Yes,
sir
it's
said,
yeah.
we can't know the cause, but it is okay. It is for as a screening we can do it. Yes, it is a mandatory. It is not a screening actually. Like Somraj sir used to say it. First thing is record the BP in all 4 limbs. That is good enough for a cardiology resident. So that is a mandatory actually. Okay, we'll go for the polling.
Poll questions, please. Do Indian women develop subclinical atherosclerosis earlier than Western women? So most feel that it is they develop much earlier. So we need to. So there is a point. This was raised in the IJCWD article, though it was a small study. They said, I mean, many people question doing calcium score less than 50 years. They said there's no. I mean, it can be done. I mean, rather. Next slide. Do rural women have limited access to carotid IMT and CAC score scans? So this we already discussed. So yes, 100%. Next. Next, please. Are biomarkers ApoB, HSCRP more cost effective than imaging in India? So yes is most felt yes. Next. So should India create women-specific imaging protocols? So with so much discussion, I think yes. Yes. So though a small percent feel no. So we'll go on to the next Article 7.
Ma'am, I have a doubt, ma'am. This is Anuradha.
Yes, Dr. Anuradha, please go ahead.
Ma'am, actually regarding ankle brachial index, actually my topic is imaging and biomarkers in subclinical atherosclerosis. Yes, brachial index, whether to include in the imaging or biomarkers. It will not be, it cannot be included in both categories, no ma'am.
Yeah, as
it is a screening test. It is a screening test.
Yes, as Jyotsna said, no. Okay. So we'll go more into it, Anuradha. We'll go into the more data and then check it. So we'll go on to the next thing.
This is about the statin therapy myths and the nutrition. And myths, that is especially infertility, weakness, a stronger deter Indian women from the statin use. And as we already know that Indian women usually have the myalgias much more frequently than the other population. And this worsens the treatment gaps. And poor adherence to the drug therapy results in the higher recurrence events and preventable deaths in Indian women compared to the men. Out-of-the-pocket statin costs burden a long-term adherence. Government scheme should subsidize it. In some of the governments, I heard that they are giving the statins or also along with the antiplatelet drugs to the few of the projects, especially Telangana government started giving it. And Indian guidelines must integrate the yoga, nutrition, the lifestyle alongside pharmacotherapy for a better female acceptance. Sarita, please.
Next slide, please. So this article number 7 has been written by our lead author, Dr. Rama Mohan, who is with us, Professor Bhaktavastala Reddy, Dr. Sharmili, Dr. Madhuri, and editorial role is by Dr. Rupali Khanna, who is also with us. So we've been discussing a lot about statins from right from early use during pregnancy and post-pregnancy and post-breastfeeding. And we've looked at all of the contraindications of it. We've also looked at the problems with adherence in this and about lifelong therapy. So, and also about being more aggressive with it in women who are at higher risk, and also about the change post-menopause. So since we have Dr. Rama Mohan and Dr. Rupali Khanna both with us currently, so the lead author and the editorial person can both give the recommendations.
Yeah, Dr. Rama, you want to start?
No, madam. You only start, madam. Rupali Khanna.
Okay. Okay, Rama. Yeah. So I don't have sent the recommendation till net, but what I read about it, and I can just summarize it. One and most important with women, which I want to say, statin therapy and all that. First and foremost, these are having, if you see the review article, there was them having a premenopausal age much earlier than what we are seeing in the patients with a postmenopausal. We are at least 10 years younger to the Western population. So which this thing, I think with Indian population, this has to be emphasized that these patients should be monitored very closely in these cases. The statin therapy should be started in these cases when they, because of the early menopause, which is itself is a risk factor. Age of presentation in these cases, it should be because these are younger age women presenting to us. So these patients should be having a statin therapy earlier. The intolerance part, whichever I searched, that there was more intolerant and side effects of SAMs in these cases. So the recommendation would be that these patients should be started with a low dose, and depending on this, we have to modify the dose. The third part of yoga and nutrition, frankly speaking, I didn't find much studies or randomized controlled trials comparing these things. So I will go into in depth of more because I have not searched till yet of yoga and nutrition part. So at present, I cannot give a clear-cut recommendation in these cases. Maybe in another few days, if I find some good study, because I didn't find any good study about these nutrition and the yoga part of these in patients with dyslipidemia, especially in Indian women.
Rupali, what you are
Rama,
quoting
you want to
from
add
the
something?
Indian studies?
Ma'am, yoga, that yoga
No, no,
and
not
the
the yoga.
randomized
Other
control trials.
other components, you're talking about the
Ma'am,
statin.
SAMs, I found statin and I found review articles and some analysis for the Indian women in this presenting about your SAM, your statin intolerance thing. I found them in the research article, and regarding the statin therapy initiation, especially in women, the premenopausal and the early age of presentation, it is definitely more in the much earlier in Indian women as compared to your Western population.
My
These two
question
things I
is
found, ma'am.
if the studies are available, or the reviews and case reports and short non-randomized.
Reviews and case reports, mostly reviews and case reports are there. We don't have a randomized controlled studies, ma'am. From Indian subset, no.
Yoga study is there, Rupali. One, this.
Which one?
I think there was maybe I'll share it. So I think it was an ICMR conducted study in which yoga and its hemodynamic effects, cardiovascular benefits have been studied. And
But that's a study. If which I searched about, I told you yoga. I didn't search more, so maybe
yoga is
I will be
available.
better able to
I will
tell.
quickly share. I think Dr. Durairaj Prabhakaran was one of the leads for that study only.
Okay.
He was there. So that
Okay.
study is there. Maybe I'll share it. Yeah.
Probably
Yeah, thanks,
Raman can say tell about it because he already finished his article, and Indian studies are available on this topic.
No, madam, not much. Very few case reports are there.
So do we go ahead for a poll and any expert comment? Sujata ma'am?
Yeah. Dr. Ramohan wanted to add anything?
No, madam, nothing, madam.
So we'll go ahead with the poll.
Yeah, okay, madam.
So are myths about statins, infertility, weakness stronger among Indian women than Western women?
Hello.
Go on to the next question.
Nothing like that. ஒரு மீட்டிங்ல இருக்கேன் இல்ல வீட்லயே இல்ல even கல்ல பரவாயில்ல சொல்லுங்க
Can
நான்
show poorer adherence to statins compared to global average. So I don't know if there is data on that. As I said, as Jyotsna has already said, these are not to be added as recommendations, but these are questions which should be considered in our statements. So somewhat poor and yes, very poor. So we should look at data which looks at adherence. Next.
For this, Sujata, there is an evidence. That is, adherence is very poor. There is a comparative this thing.
Oh, that's good. Great. Next. So is cost a major barrier for long-term statin use in Indian women? Next. Yes. So it's on 50% felt cost is a major risk factor. Somewhat is by 35%. Next. So should Indian guidelines integrate yoga and nutrition alongside statins? So yes, most felt yes. So we go on to the next question, next article.
Yes, ma'am. Article 8, National versus Global Guidelines. Discussion domains are social, cutoffs, protocols, and national guidelines. Indian women are under prioritized in guideline training. Gender sensitivity remains weak. Lower cholesterol cutoffs for South Asian women may be better predict risk than Western thresholds. Western protocols inadequately apply to Indian women. Local culture, dietary context, and it requires customization. India should issue gender-specific national lipid guidelines for effective cardiovascular prevention. Next slide.
Sarita?
So this article number 8 on national versus global guidelines, the lead author is Dr. Dayasagar and the editorial role is by Dr. Saiko Takahashi from Japan. And what she has sent is that what emerges from the entire review that she has done. She has looked at US, she's looked at UK, she's looked at Canada, she's looked at Japan, she's looked at India and Poland and 1-2 other countries. Now what she said, and she summarized it, that first, although sex is incorporated into most of the cardiovascular risk score, these tools do not always capture women's cardiovascular risk in a comprehensive manner. Second, she said that LDL-C targets differ across guidelines, but are uniformly applied to men and women both. Third is the use of statins during pregnancy and lactation remains contraindicated. Finally, consensus on how to address female-specific risks in cancers is still insufficiently developed. Current international dyslipidemia guidelines generally recommend uniform LDL thresholds for both sexes with preventive strategies which include statin, estimab, and PCSK9 inhibitors guided by overall risk stratification, CV risk stratification. Although such consistency offers clarity, it may overlook important sex-specific nuances. In clinical practice, lipid screening typically begins later in women than in men, reflecting the protective effects of the premenopausal state. However, widely used risk calculators such as the pooled cohort equation in the US and the SCORE system in Europe are not validated beyond the age of 80. Given women's longer average life expectancy, this limitation introduces uncertainty in evaluating CV risk in older women, often bear a substantial lifetime burden of ASCVD. Also, reproductive considerations are consistently emphasized across guidelines, and statins remain contraindicated during pregnancy and lactation, and women planning pregnancy are advised to discontinue therapy in advance. In cases of severe familial hypercholesteremia, bile acid sequestrants or LDL apheresis represent relatively safe alternatives. Again, life events and comorbidities disproportionately affecting women, such as premature menopause, pregnancy complication, and autoimmune conditions, including SLE and RA, are increasingly recognized as risk-enhancing factors. Without systemic integration of these conditions, many women may be misclassified as having intermediate risk, which could delay the initiation of preventive therapy.
Thank you, Sarita, summarizing the
Hi,
article.
Dr. Psycho. Good to see you.
Yes,
got
good to see you.
joined. Dr. Psycho, now that you're live, thank you for joining so much. Some
Oh,
comments
thank
from
you.
you,
Thank you for having me.
from your article.
Yeah, like you summarized that overall current guidelines do not provide detailed gender-specific recommendation. I think that's why we need like a national guidelines, because I think there are differences in race, body size, and healthcare systems and procedure approaches and the standards of care. So I think it's a great idea that Indian society has a women's guideline for the dyslipidemia. Thank you for giving me this opportunity.
I think you've done an extensive review of all the countries and you've compared it. And thank you for all the work that you've put into that in comparing all the global guidelines. Just for this thing, how do you all use statin in pregnancy in people who are at very high risk in Japan?
No. Usually, Sarita, Japanese people are healthy, so our LDL target is still like high compared to the other countries, and we don't have many female patients who need statin when they are young. So I think maybe race, genetically, we are a little bit different. So I think it's interesting to know that we need to use maybe statin for the high-risk patient. But how about in India?
Yeah, so really very interesting. If even in India, I don't think, I mean, statins are not really being used in pregnancy. And as you mentioned that they were, initially the word was absolute contraindication. But now with FDA, giving us some degree of relaxation in female patients who are high risk, for instance, those who have familial hypercholesterolemia and who are already on these drugs, and there are some predisposing conditions. For instance, they've had some coronary event in the past, and or expected events given their risk profile. So individualization in the high risk and use of statins has been mentioned by FDA. Though still the drugs of choice, if at all, in pregnancy, they remain, bile acid sequestrants and others, as we discussed. So pravastatin is the drug which was actually studied in patients who were having eclampsia and preeclampsia, primarily for the benefit of hypertension related adverse effects. However, no teratogenic effects were found in the fetus. So this is how it is, but I really do not know. To some patients whom I did recommend statins, they denied to use it in pregnancy, even they were at high risk. So the house can give the opinion.
Yes, but I checked. Please.
This is Dr. Dayasagar. Can I make a comment?
Yes, surely, sir. Yes, sir.
Yeah. I just wanted to know whether in Japan, do you differentiate between hydrophilic and lipophilic statins, while choosing the statin for a pregnant woman?
We don't have data for that. I never prescribed the statin for the pregnant woman, so I don't know.
No, now that the people are getting married late, they're having tests for pregnancy, and they are having pregnancy.
Yes, that's a good point. Yes.
Please.
Yeah, that's interesting.
High risk.
Yes.
They prescribe a statin, but in the prescription of the statin, do you make a difference between the hydrophilic statins and lipophilic statins, because the pravastatin is supposed to be hydrophilic, and that has been changed. So do you really make a difference when you are prescribing it? Whether to use, or you specifically advise to say it's only hydrophilic statins? Do you have any data to that effect?
Thank you.
Yeah.
Very interesting. Yes.
Yeah. Right, sir. I mean, your point is very well taken, the crossing across the placental barrier and hydrophilicity. So,
Yeah.
and we have studies with pravastatin, though
Yeah.
definitely not Indian studies. Yeah, your point is very well taken. Thank you, sir. Do we move ahead with the,
Question. Yeah, we'll go with a poll. I think expert opinion already. Poll, please. So,
Yes,
I can't see the question. Shiva, if you can see the question, read it out.
No, we can't see the poll.
I can't see the question as yet, ma'am. May I request the host to please show the questions?
We have launched the poll, ma'am.
I can't see the
There is
poll.
no any response.
See it? Can you launch it again?
We can't see.
Yeah, now it's
socially under prioritized in guideline framing. So I think without the poll question, yeah,
There are no options.
no option. So we can go on to the next question, please. Let's not waste time.
Yes, ma'am. Yes, ma'am. I have launched the next question, ma'am.
Should cholesterol cutoffs be lower for Indian women than for Western women? So most feel yes. We go on to the next question. Are Western guidelines fully applicable to Indian women? Partly, most feel partly. So next. So should India issue gender-specific national guidelines? Okay, so most feel yes. So we'll now go on to article number 9.
This is about the inclisiran and siRNA therapies. Inclisiran or siRNA trials must include the Indian women. So far, I heard that inclisiran studies have started, but recruitment of the females are quite less in that. So we have to involve the pharma companies to increase the recruitment of the females. High therapy, the cost disproportionately impact the women with the lower financial independence. And older generics, statins, ezetimibe, remain more feasible than siRNA drugs in India. And low awareness among the women about the novel lipid therapies contributes to the inequality.
Can you go to the, okay, so this article 9 has been, the lead author is Dr. Ramya and co-authored are Dr. Chandana Shekhar, Dr. P. Sheshagiri Rao, Dr. Tripti Dev, Dr. K. Dipti. And we have the editorial role by Dr. Cecily Marie Magella. Now, what they have given is that inclisiran can be used in patients with hyperlipidemia where LDL-C is not in the recommended range in spite of maximally tolerated statin or other lipid-lowering therapy. However, since the evidence in India is limited to small real-world series and one ongoing non-randomized phase 4 trial, the strength of recommendation is class 2B level C. In diabetics with or without ASCVD in high risk, they've said very high risk or extremely high risk categories with LDL, non-HDL, ApoB not in recommended range. Inclisiran can be added to pre-existing lipid-lowering therapies. Strength of recommendation class 2B level C. Inclisiran can be considered as a first choice in patients with ASCVD on maximally tolerated statin therapy with inadequate lipid control. Strength of recommendation class 2B. And inclisiran considered in post-ACS patients within 4 weeks of discharge with uncontrolled LDL despite statin therapy. Strength of recommendation class 2B. They've also said inclisiran may be considered in treatment-naive adults without prior ASCVD, diabetes, or familial hypercholesteremia with elevated fasting LDL of 190 and 10-year predicted ASCVD risk of less than 7.9, strength of recommendation class 2B, they have said. And I think I can see Dr. Ramya here, who's the lead author. So Dr. Ramya, do you want to make some comments about this?
Yes, ma'am. So in this review, we have reviewed mostly international trials because we have very little data from Indian studies, ma'am. Some of the trials like Orion 18 was done including Asian subjects, but we don't have specific publication to show what is the data they have. And there is an ongoing trial which is called Victorian 2 Prevent, which is including Indian subjects, but it's an ongoing trial. So we don't have any clear-cut randomized trials. All the international data have clearly demonstrated that inclisiran is effective. It can reduce LDL by more than 50%. But the issue is we don't have Indian data on this, and data on women are even more limited. We don't have any specific studies at all. Only two observation studies which have been published include one was included 16 patients, the other included 60 patients. Both were observational studies, so we cannot, though we know it is very effective, but we have limited data on this, and there is no representation or any specific studies for women. So that is why the level of recommendation has been given as only 2B. Other than that, we don't have much data on this one.
True. And you've also given some recommendations about evinacumab, and you've also given a recommendation for olezarsen. Would you like to elaborate on that? Both have been given a class 2B. Would you like to elaborate on that?
These two drugs are again not studied adequately in India. They're actually not available in commercially. It's not yet approved in India. They're only given by specific prescription, only by some specific distributors who have to import it from US or UK, and they are now used only as investigational drugs. But we have
the Essence and the Balance you've mentioned are both ongoing in India?
Ongoing. No, ma'am, they are part of it. Yes, ma'am. Balance study and Essence study both are part of it. Indian subject studies are ongoing, and INOS Industries has actually published recently that they have seen promising results in reducing triglyceride levels. But these are not published data. We don't have proper literature on this. These are only the results given by a company, so which cannot be taken as a validated data to give a consensus statement. So whatever data we have on all these drugs are only from Western literature.
Excellent. Excellent points. Dr. Cecily is also here. Dr. Cecily, you're on mute. Dr. Yeah.
Yes, ma'am. Yes, ma'am.
Yes, Dr. Cecily, some comments from.
Yes, ma'am. As rightly mentioned by ma'am, there are not much studies of inclisiran to differentiate between males and females. But in circulation, which has included more than 3,000 patients, they have found out that inclisiran, though the baseline LDL is higher in women when compared to men, the reduction is similar in both males and females. Only thing, the injection site reactions with inclisiran is higher in females when compared to males. It is around 9.4% in females versus 0.2% in males. This is in consensus to the Orion study, which has been published in 2020, which has included 3,660 patients totally, comparing males and females. So the reduction, the females present with baseline higher LDL levels, the reduction is similar to both males and females with inclisiran, but the injection site reactions are higher in females, 9.4% versus 0.2%. Whereas from Apollo Chennai, by our own team like Sengatuvalu sir, Damodaran sir, everybody, the Indian, they have seen for males and females, they found out that within up to 75% reduction of LDL has been found, but the reduction in males, in Indian males, is 74 plus or minus 12%. When compared to females, the reduction is 69.34%. And we have to keep in mind that women, Indian women, are not tolerant to high intensity statins, and most of the Indian women, they are already on not in full dose high intensity statins, but in either moderate doses or lower intensity statins. Therefore, the LDL variability in Indian women is far higher, which is also an important predictor of atherosclerotic cardiovascular disease. And for such patients who have high risk of atherosclerotic cardiovascular disease, I think inclisiran in Indian women has got a role, but we know the cost issues and other things we have. And another important thing is the role of inclisiran. It has got a good role in homozygous familial hypercholesterolemia, but we have to remember that in heterozygous familial hypercholesterolemia, it doesn't have a much role. So it has to be combined with the evolocumab, or who are already on maximum statins and estimate dose to achieve the proper LDL target levels. We have to keep in mind while using inclisiran in heterozygous familial hypercholesterolemia, it is important that inclisiran may not be that much effective, whereas it may be effective. It is very effective in all other situations. And there is also a portrait this study which shows the sex differences and the lipid LDL lowering. But as rightly mentioned, there are not lot of data as to assess these things. And coming, I would like to just mention one more point is regarding the diet in Indian women. There is also a study which has shown by Reddy et al., which has shown that in women, the vegetarians who take, we consider that these are of, they have lesser risk for the LDL levels are relatively no, it is not so. That vegetarian women of Indian descent, irrespective of their dietary intake, the LDL levels are not much changed. This is the data written by Dr. Reddy et al. And we have to, when coming to the newer molecules, I would like to just mention that apart from the when we have this angiopeptin-like protein 3 deficiency, among the angiopoietin-like protein, which is the most important are the 3, 4, 8. So it hasn't been studied much. The sex differences hasn't been much studied. It is a point. It is a future studies have to bring in with the newer molecules. So it has been shown that these drugs, this angiopoietin-like protein blocking antibodies, the evinacumab, it has shown to very well reduce the triglycerides, which is quite more common. The hypertriglyceridemia in women is generally more common than in men. So these newer molecules, which reduces the triglyceride levels up to 73% and the LDL to 27%, these has to be, there are just trials are just going on. There is, we may have the data on male female differences, but we should also keep in mind that these targeted therapies, their role and everything. And also we should, as madam has rightly mentioned, this antisense oligonucleotides, ASO, targeting the hepatic angiopoietin 3. It is very helpful, and it has been the phase 1 trial which shows that for 6 weeks, the triglyceride levels reduces by 63% and the LDL by 32.9%, whereas no changes in HDL. Whereas the previous molecules, it reduces the HDL also, and these newer targeted ASO targeted hepatic angiopoietin 3 levels, they do not change the HDL levels and not much side effects, and they're more tolerable for women, but still we should have larger data to show these things. And when coming to the familial chylomicronemia, which is yet has to be studied in detail, the gender differences of familial chylomicronemia, both in males and females, wherein the olinorsarsen plays a role. We have to this ApoC3 targeted therapies has not much data is still available, and these drugs, mainly the newer molecules olezarsen and the plozarsen, they have in additional benefit a major role in acute pancreatitis, wherein the TJ levels are very high. So I think among one important thing with the PCSK polymorphisms, as mentioned, there is one study in the North Indian population which has been reported. The polymorphisms are still present. It has been associated with increased risk of coronary artery disease, especially in the North Indian population. The polymorphisms, which include RS505, 151, it has shown to increase the risk of CAD in North Indian population. It has been documented, whereas the heterozygous genotype conferring higher risk. This confers higher risk. Whereas we have to remember in PCSK9, the RS50515 G allele, if it is AG or GG allele, it has got a protective effect against CAD. So definitely PCSK9 polymorphisms do exist, and there is Indian studies quoting that, especially with an increased risk of CAD in the North Indian population. I think these are all points of concern. More and more depth into such things has to be kept in mind. And thank you so much, ma'am. I was little busy, still in the hospital. Had to take a primary, ma'am. Sorry. I couldn't bring the PowerPoint, ma'am.
Excellent to hear a extensive review by you, but we wanted in writing. We are
Yes,
not
ma'am.
getting
Sure,
anything
ma'am.
in writing. That is a major problem. I want to tell to the Rupali also. We want everything in writing. The same thing
Yeah,
if
we'll
you have to be
submit, ma'am.
sent by the writing, that
ma'am.
might have been decreased over the discussion. We directly would have been gone. So that's what I want
Sorry,
to
ma'am.
increase the write-up.
So sure,
See,
ma'am.
all these things you would have been sent as a write-up would have been known to everyone by this time. Thank you.
Yes, ma'am. Sorry, ma'am. Sorry, ma'am. Sorry, ma'am. I will do it, sir, ma'am, by tonight.
Do it for
Thank
this
you.
time. Yeah.
Thank you, ma'am.
Yeah, Article 10. Ramohan, please.
Madam, we have to go for polls, madam.
Yeah, we'll directly go for the polls. I think we have the very less time. No, the Ritu is the wrote this article.
Yes, ma'am.
Yeah, please go ahead.
Yeah. CETP, LCAT polymorphisms are common in Indians, impacting HDL quality and function more in women. Poor HDL function leads to premature CAT despite normal HDL. Lifestyle intervention outperform costly drugs for raising functional HDL, and India should prioritize women-specific HDL therapy trials. But basically, all these targeted therapies should be focusing more on the quality and function of HDL rather than just on the quantity of HDL. CETP inhibitors had safety concerns since 2007. We didn't have any good CETP inhibitors, but the latest Cetra PIB did show some promising result. I think we have the next article on that only. ApoA1 mimetics are better anti-inflammatory. They have better efflux capacity to enhance cholesterol efflux capacity for macrophages, and they're better in improving the endothelial function, especially CSL112. Which was recently, AGIS-2 trial, did show some promise, but over a longer duration of time. And especially if these drugs are combined with lipid lowering agents like statins or maybe PCSK9 inhibitors, they might give us a better protection against CAD-MAP. Yeah, that was my.
Dr. Ritu has given a consensus scientific statement also.
Yeah.
You want to read that, Ritu, or you want me to tell it?
Ma'am, you can tell this. I mean, I did.
So she's done the consensus and she's written that there's comprehensive evidence that CETP inhibition reduces MACE by lowering LDL-C and HDL. Increase is irrelevant for ASCVD. The concern of AMD with elevated HDL has not been addressed as yet. She's given a class 3 recommendation, level of evidence C. Second point she's raised is that CETP inhibitors may only be used as add-on therapy with statins, PCSK9 inhibitors, only in the subgroup with very high LDL levels despite these drugs. Class 2B, level of evidence C. Third is her last phase, which includes follow-up beyond 90 days, will determine consideration of APO-1 mimetics usage after an acute MI, currently class 3 recommendation. Fourth point she's given is we recommend daily exercise, diet, maintain healthy weight, and to quit smoking. Class 1 recommendation, level of evidence A.
Yes, ma'am.
Yeah. Good evening, ma'am. This is Dr. Jayashree here.
Yes, Dr. Jayashree, please go ahead.
Yeah, the consensus scientific statement was written by me because I just wanted to make a few changes later after discussing with you all. So the first point that I made was that there is comprehensive evidence that this reduces major adverse cardiac events, but like all the 3 drugs, whether it was torcetrapib, studied in the Illuminate trial, it was stopped prematurely because there was increase in blood pressure and there was electrolyte imbalance, which led to increased mortality. So that was taken off. And the other 3 in the Accelerate trial and the outcomes where they used avacitrapib and dalcitrapib also, they found that although these CETP inhibitors did not prove to be harmful, they were largely ineffective. So all these 3 trials with CETP inhibitors were not very effective. But however, the REVEAL trial wherein they used the anacetrapib was closest to succeeding by reducing the major adverse cardiac events. So, but they found that when this was added to statins, the benefit was more in that subgroup of patients who had very high LDL levels. So based on these trials, we thought that this has to be a class 3 recommendation because we do not have Indian data, one, and the second, even the international data, they're all most of them have been negative, and we are now waiting for the obicetrapib trial, wherein that is a ROSE trial, wherein obicetrapib was tried in 120 patients, and they used varying doses 5 and 10 milligrams against the placebos, and they found that the HDL levels increased up to 135 to 165%. And it also lowered the lipoprotein by 33%, and ApoB and non-HDL levels also decreased. So importantly, what I want to bring to your notice is that the HDL, although elevated to 135 to 165%, one doubt I wanted to clarify with you all is, we also know that there is a U-shaped relationship observed with HDL cholesterol. So we know that low HDL cholesterol, there is increased cardiovascular risk, but very high cholesterol also there is a risk of increased cardiovascular risk, basically with mortality, and most of the time associated with malignancy and all. So treating these patients with CET inhibition, wherein you're going to have elevated levels, there was a concern which was raised by Anna Hansen, wherein she says that although these the genetic deficiencies in CETP, which the researchers say that mimics the pharmacotherapy of CETP inhibition, it was associated with higher risk of age-related macular degeneration. However, what I feel is this was seen in elderly population, but in our Indian population, we find that the HDL is elevated more in patients with polycystic ovary disease, wherein they are younger patients. So I don't know whether that is applicable to us. And the second thing is, how high do we want to go? Because the guidelines recommend that the HDL more than, even if you look at the Lipid Association of India, they say that the HDL has to be around, more than 50 for the cardioprotection. So how much more do you want to go to see whether there is U-shaped relationship which is observed with cardiovascular risk and mortality. That's one thing. And that was for the part one, rather the first statement. The second one, like I said, based on these trials, we feel that it has to be recommended as an add-on therapy only in patients who have very high LDL levels and wherein you have tried the statins, PCSK inhibitors, despite which the LDL levels have not come down. So in these group of patients, perhaps you could use CETP inhibitors in lowering, wherein they can also be elevated HDL levels, but highest being found in the ROSE trial, wherein they had used obesity trial. And the third statement, this was with respect to the APO1 mutants, when that was studied in the AEGIS trial. So in the AEGIS trial, what they found was when they're planning to study it for 90 days, 120 days, and 180 days. And in the last phase of at 190 days, they found that it was not very helpful. So they're looking at whether it's going to be helpful at 180 days. So we still have to wait for the results of this AEGIS-2 trial to say that APO1 mimetics are going to be useful in elevating HDL levels and therefore providing cardioprotection or reducing the risk of ASCVD. And lastly, we all know that none of these drugs are approved. They do not have FDA approval. They're not approved in Europe, and we ourselves do not have any data to support that these should be used. So what we have to go back is again to recommending daily exercise, diet, and to maintain a healthy weight, because invariably most of these patients with PCOS have metabolic syndrome. There is and decrease in HDL and all that. So, and also quit smoking. So these are, basically maintain a healthy lifestyle to elevate your HDL. So the drugs per se do not have a role in elevating HDL in isolation is what I feel.
Yeah, it's a nice overall view on the HDL. I think most of your questions, better you answer it because you are the better reviewer. Actually, I consider then HDL as a marker for the exercise. If the HDL is not elevated, I will say that you do the more exercise. Now, because the drugs are available, I think you reviewed the literature, so you are the better person to know about to answer those questions much better way. And please put it on writing. All things. We wanted in writing for all your
I've shared it, ma'am. I've shared this with
this whole matter is also questions and everything is also shared.
Questions we haven't shared, and actually I just want to discuss it with the authors also and just tweak it a bit, and then probably come out with a little modified or rather an edited
because now the
version.
limited number of the people are there. I think you can put this in our group.
Yes,
because we can continue this discussion till we get the issue. So
Yes,
that time we can take the advice of the other people also. Anyone
But as of this, what do you feel, ma'am, this recommendation that we have come up with?
I have not actually gone through. Just now I heard Sarita Rao reading about it. So can we have the discussion once I go through the comparison?
ma'am.
What I want
Yes,
is
ma'am.
evidence-based. If that
Yes,
is
ma'am.
evidence-based, yes, I will accept it. That I
Yes,
have to
ma'am.
check it.
Seems
Yes, ma'am.
reasonable, ma'am. I also just received it just now,
Yes,
5 minutes ago. But I read
Yes,
what
ma'am.
she's written and the evidence that she's written about it. So it seems quite reasonable. But Jyotsna ma'am will go through it once and then finally we'll let you know, Dr. Jayashree.
All right, ma'am. All right. Thank you, ma'am.
Yeah, we'll go for the poll of 10. 10
Yes,
poll is
ma'am.
over.
Yes.
Yeah, please.
Even 9 also, Miss Ma'am.
Yeah. You can continue. So should India conduct inclisiran sRNA specifically in Indian women? Is it an urgency or? Urgently is 82%. Next. So are affordability barriers stronger for Indian women than men?
Yes.
Much stronger is what everybody feels. Next. So come on. Sometimes you're going back.
No, then I think it's better to read from this question because that result will come there. No one knows the question. It is like that.
We need to go ahead for the next question because
Are
it has ended now.
siRNA therapies unaffordable for most Indian women?
So they
I
can't
think,
do it because the poll has disappeared.
okay, next. Are older agent statins estimated more cost effective than siRNA drugs in India? Yes. Okay, next. Continue till 40.
Yes, ma'am.
Do Indian women have poorer HDL quality function than Western women? So most feel much poorer and slightly poorer. So next. Are CATP and LCAT polymorphisms more frequent in Indian women? So most feel yes. Next. So are lifestyle-based HDL interventions more cost-effective than HDL drugs? So yes. Next. So should India prioritize HDL targeted drug trials in women? So yes, no, I'm sure almost. So I think we'll go on to the last article.
No, the last article is about the novel agents. So I think it's directly we can go for the poll because with these novel agents, all other drugs which are already in use itself, we don't have the randomized trials. So there is no question of having any on this. So I thought this is only for the completion of dyslipidemia in the woman, this chapter, and we are not expecting any scientific statements out of it. So directly we can go for the poll.
Yeah, but the author can comment on, are Indian women underrepresented in clinical trials of normal lipid drugs?
Oh, he launched. I think it's better to finish this, otherwise this goes off.
Yeah. He'll finish and then take comments from Priya.
I think Priya has joined, so we'll take. Please go to the next poll question.
Next, 42. Should Indian regulators demand Indian-specific female subgroup data before approving novel agents?
Actually, there is a major drawback. If they do that, then many of the studies will include them.
Next. Are novel lipid drugs unaffordable for most Indian women? The last question. So very unaffordable and somewhat unaffordable. Next, last question for today. Should India build a women-specific registry for novel lipid therapies? So most feel yes, and we can go on to the.
Poll is done, Dr. Sujata.
Yeah, it's done. 44%.
Final comments from Dr. Priya on this topic.
Yeah, so basically, these are novel agents which are still in phase 2 and phase 3 trials. And what we have is we have Pelacarsen, which is an LPA lowering drug. These are basically drugs for LPA lowering, Pelacarsen and the other ones which are along with it. LPA, as we have all just discussed, is higher in women, and in this particular drug, what they have seen is for the trial, what they have seen is that LPA raised is associated with more atherosclerotic coronary artery disease, aortic valve calcification, and 37% increase in peripheral vascular disease. And as against inclisiran, which causes only 21% reduction in the LPA, Pelacarsen causes 80% reduction in LPA, which was seen in the last study, which was a phase 2 trial. And the current phase 3 trial is still underway. The results are expected in 2026. Other than that, the other drug that was given was obicetrapib, which is a CETP inhibitor, which reduces the LDL and increases the HDL. It's basically being studied mostly in familial hyperlipidemia. In the Broadway trial, 34% women were included, and it showed a decrease in LDL by 29%, as against previous CETP, which were failures actually. So in this particular trial, they have had 4 arms where they had only obicetrapib, only ezetimibe, combination of the both, and only placebo. And the obicetrapib plus ezetimibe combination drug, which was given upfront, showed a 48% reduction in the LDL, as against only obicetrapib was 27 and only ezetimibe was 16%. So what they have said is giving combination of obicetrapib with ezetimibe, which causes the real LDL reduction of nearly 48%. So all the other, there are different other molecules also which are all in phase 2 trials. So as regards safety, they have been found to be quite, besides efficacy, they have been found to be very safe also. There are just very minor side effects seen, like flu-like symptoms or acid reflux symptoms. Nothing specific has been reported as yet. And LPA, as we have all just discussed, does change with certain diseases like liver, kidney diseases. It changes with hypogonadism. It changes post-menopause. It changes post-myocardial infarction up to first 6 months. So LPA once in a lifetime is not sufficient. It should be repeated again in postmenopausal women and in patients who have had a myocardial infarction within the first 6 months, so that it can be treated appropriately with these new agents. I think that's just about it.
Thank you very much. Actually, I thought of asking the Shiba to tell about the poll result, but this is too late. So I think it's better if the Shiba share her the poll result of not the poll result, the Google form results separately. Just to conclude, I have the 4 important points to say. From the Dr. Prabhakar, he suggested to collect the data from the Apollo hospitals. Please, Sarita, you take lead of it, because many of you are from the Apollo. Asha, Mahilamaran, and many of the I can quote as from the Apollo. So please try to. That is a good idea. I suggested this before, if you remembered. Then from the Tripti, strong family history of the patient should be the checked at 10 to 14 years of the menarche time, and start a strict lifestyle and strict follow-up for LDL and LPA follow-up at a yearly by the binary times period, and targeting the heterogeneous women. So her recommendation of the earlier screening may be the more useful, and this point is also discussed very well before. So I wanted the opinion. Everyone says before 40 years. I think that is too late. Please, you go for the literature and suggest the appropriate age. Third one is during pregnancy, diet and dyslipidemia was raised by the Rupali. Just now the Shabbi confirmed it. Yes, she has done it. I hope she joined it. If she joined, she can explain that. Or otherwise, just now she rang up and said that she has an evidence to say that, yes, in pregnancy. And can we as a Vinkar group take the lead in getting our results tested and start the data by Mohanjit? That is true. We are about 250 members are there. We can say that this is our the lipid profile, our age group, our the risk factors, and we can have the data of our own Vinkar's people. My question to everyone now, with this limited data of the literature available, everything should we downgrade it to as a class 2A, class 2B, or should we write as a, because of this limited, we are giving these recommendation is going to be good?
I think
Go ahead, Dr. Sujata.
If there's data on Southeast Asian women, we can say a class 1A recommendation. Only if there is no data, then we can say. We can apply the Southeast Asian data to Indian women, right? That includes the Indian women. There are a lot of studies on Southeast Asian women. What do the others say?
Ma'am, just talking about the HDL, the emerging drugs in HDL therapy, we don't have data. Like you said, that the data they have studied in the CET inhibitors are from, patients, the Indian population in Singapore or the Indian population in UK. It's like that. Or in Southeast Asia, like Malaysia. So we don't have our own number. So maybe we can extrapolate it like you said.
Yeah, we write that limitation. We say that is not the direct racial or ethnic classification we did it, but we extrapolated to this, we can say it. That's
Yes.
why I'm not sure, should we write as a recommendation or...
I agree with you, ma'am. I agree with you because it doesn't really make sense to say class 2, 2A and level of evidence A, B, or C because we don't even have the data, and even the recommendation has not even gone into the the bigger guidelines like the ACCHA guidelines, or they are only not recommending it yet.
But every recommendation, what is coming from India, that is the same. Even Lipid Association is bringing out, hypertension is bringing out.
Yes,
Many
ma'am.
of
Even
them
they haven't come
doesn't
out
have the randomized trials.
But so for some of these novel drugs and some of the other, like purely for
Novel drugs, anyway, we are not writing it now.
yeah, we
Novel
don't
drugs,
have
as
data.
just now Priya said, we are not writing the recommendation for that at all. We are not thinking.
That's what it's
But
better not to
statins, they're
write.
there
It's
since a
better
long
to
time.
just
Yeah, this is
just to
Dr.
make the
Dash Sagar.
statement.
Yes, sir.
Dr. Dash Sagar speaking. Can I say something?
Yes, sir, please.
Somebody said Southeast Asia. India does not come in Southeast Asia. South Asia countries are different. India, Pakistan, Bangladesh, Maldives, and Bhutan. Southeast Asia is totally different. So our data should be focused on South Asians, not on Southeast Asians. Second, when we do not have any randomized clinical trial, we label them as consensus statement, not as a guideline. So it will be recommendations.
Yes.
But I think while we write the consensus statement,
Yes.
we need to make an effort to produce some randomized clinical data. So that is going to be the future, or that is going to be the target for the WinCars. So we need to create our own data. The next decade is going to be only data analysis. So we need to have data for analysis. And it should be in thousands, not in hundreds. Then only we will have any statistical relevance and the clinical importance. And everybody else all over the world should be able to say this data is worth looking at it. If we do only in hundreds, it is not good for anything. So we have to do in large numbers, 100,000 minimum. Then only it will be useful. It should be randomized trials. And we need to have a research team in this group so that somebody should formulate and think and then write down what is the missing data here, or what are the lacunae what we have in our country. Then only we can go further and then produce some world-class data. Here we need to take the help of epidemiologists, and then probably they will be able to help us in knowing what is the desired number to get it, to have a what we call statistical relevance and statistical applications. So this is my understanding of the whole thing. Whatever, this is the first WinCars conference I have attended, or the meeting. It was a good meeting, good exchange of ideas. Everybody has done some reading, and we have got more questions than answers. It's good. So there is a more material for future research, because since we do not have data, this generation has to start, and then we'll have some enough data for the future. That's my recommendation or consensus statement.
Yeah, thank you very much, sir. That's what I was doubting. So consensus, we write as a consensus statement.
Yes.
Thank you very much, sir. So Shiva, you wanted to give the vote of thanks?
I think it's been a great day, and this World Heart Day has been very special. I would like to thank each and everyone who has been there in this meeting and closely associated with the formulation of the consensus statement. My special thanks to our patron, Dr. Jyotsna Madhuri ma'am, our chairperson, Dr. Sujata Viparla, our president, Dr. Sarita Rao, and of course, the esteemed senior faculty of the day who have spared their time to be here today. I would like to make a special mention and thanks to Dr. Dayasagar Rao, Dr. Prabhakaran, the Rairaj, Dr. Soma Raju, and of course, our very senior faculty members like Dr. Anita Saxena, Dr. Shiba George, Dr. Geeta Subramaniam, Dr. Aarti Dev Lalchandani. I hope I'm not missing out on the very senior members of WinCars, and a very special thanks to each and every one of my colleagues and friends who has been around and has contributed in immense potential to this consensus statement. My special thanks to Dr. Rama Mohan, and who has been working very hard for this document and preparing the PPT slides. My thanks to Dr. Pavani and Dr. Kumar, who have always been around, and to all the contributors, to Torrent, who has supported us for the occurrence of this meeting, to Mr. Ambrish, to the entire faculty. Please, if I'm missing out on any of the names, it's thoroughly not meant to be so. My thanks to each one of you. And let's hope that this coming World Heart Day, we pledge to move ahead with the creation of more data and improvising ourselves. And as Dr. Dayasagar has said, that this is a food for thought, and the next decade should be a decade of data collection, analysis, and building up of a good research team at WinCars. Thank you very much once and all. Thank you. Bye-bye.
Thank you, everybody. Good night, everybody.
Good night. Bye-bye.
Just one request to all editorial members who are in charge of the articles. Please make sure that the final edit comes in.
Yeah,
half of them have not achieved, and half we received 5 minutes before the meeting.
Yeah, I request everyone to submit the full articles with the scientific statements and everything. And I am very thankful. Many people have sent at least in the last minute, but I wanted to the journal is much more than important. And another is someone is asking that others has not come. What is our role? It is not our problem when they are not coming. So I request everyone to represent whenever we wanted to submit something. Thank you very much. Thank you all. Good night to all.
Thank you, everybody.
Madam,
Good night.
can I tell just one sentence?
Good night.
Madam, yeah, Dr. Sarita.
Abhi ma'am, yes.
Yeah, I just joined late. I just want to say, can we have ethical allowance?
ఈ రోజు కూడా కొద్దిగా టైర్డ్ గానే ఉండింది
Can we do
యాక్చువల్ గా
in
నిన్న
pregnancy to have
Ma'am, your voice is disappearing. What did you say?
నిన్న
Can we
ఇంట్లో
have?
ఉన్నప్పుడు బాగా టైర్
in
అయిపోయాను
pregnant patients? Because there is some ethical consideration,
సరే
so this is not
ఇంకా
happening.
అమ్మ ఇంక వచ్చేటప్పుడు రిష్ చేసింది
Can we do?
రిష్ చేసినాక కొద్దిగా కవర్ అయ్యా
We
ఇంకా
are just
కొద్దిగా నిద్ర
deriving from other studies and giving our own
కొద్దిగా టైర్డ్
opinion.
అనిపించింది
But
కానీ
can we
కొద్దిగా
try
పర్లేదు
a drug in
నేనైతే
We try
4
what,
అయ్యింది
ma'am?
అంత
We can't hear
డల్గా
you.
నాకు
Somebody
ఈరోజు
is speaking in
టైర్డ్ గా
between. Whoever is speaking in between, please go on mute.
I am
Abhi ma'am,
Mr.
what? Abhi ma'am, you're on mute.
Okay, I just want to tell, because there is ethical consideration, we do not have such evidence. Because in
Yes,
pregnancy, to try a drug, there is ethical consideration that limits the study. So whether
Absolutely.
we can try and have our own consensus or we'll give our own expert opinion. That is what.
So,
Can we
ma'am,
try a new drug in pregnant patient
we
to
can't.
produce? That's what
There
I'm
will be,
saying. Because,
ethical committee will never clear it, ma'am. So we
yeah,
can't
that
try
they will never
anything
clear.
new. Even for pregnant patient, giving statin is a huge challenge. We can't, most of us are not giving. Even we asked Dr. Saiko, who had joined into the meeting from Japan, even there they are not using. So we
Yeah.
are not using, it's not for pregnant patient. This is for the entire lifespan of a woman that we are making this, ma'am.
Almost.
Right from
Almost.
adolescence. So it's from adolescence to pre-marriage to post-menopause to elderly age. This consensus is for everything in a woman's life. Right from the time that she is born to the time she dies, not just pregnancy. Pregnancy, ma'am, is only one part of it. So in pregnancy, we have not made that recommendation. We have said that it has to be shared decision, and especially only in very high risk patients who can't do absolutely without the drug. Even then, it has to be an informed consent and shared decision making.
Yeah.
But
It's
this
a
is
safety
about
issue.
everything else also. So that is, ma'am, just one part of it, pregnancy. The rest is all of it, right from the time she's born to the time she dies. Many parts of it are there, ma'am. So I'll send you that, all the articles. There are 11 parts to it. Right, ma'am?
Maybe before adolescence to after menopause, we can try some drugs. But within that
Yes.
period of fertility, we can never try
Pregnancy,
the
we
drug
cannot
to
give
give
it.
it.
No country in the world will give us the ethical clearance. Especially in India, we will never get, and we don't want to try that also because it may be harmful.
Right.
Right, ma'am.
Thank you.
Thank you so much, ma'am. Okay. Good night, everybody.
Good night.